So let's start with the head and neck neuroanatomy. This chapter is very important chapter and confusing also. So first of all, if you go for this cranial nerves, there are 12 cranial nerves. You can see 1 to 12, 1, 2, 3, 4. You have to just remember each cranial nerve basically olfactory, optic, accumulator, trochlear, trigeminal, abducent, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. Out of this, I just marked with the green. These are totally sensory. How to remember this? First two, olfactory and optic. They are first is for the nasal sensation of smell. Second is eye for the vision, and the eighth one is vestibulocochlear. You can see nose, eye, and ear. Special senses. These are purely sensory. Sensory 1 to 8. Nose, eye, and ear. One is for the smell, second is for the vision, and eighth is vestibulocochlear, it is for hearing. These three special senses, these are purely sensory. Then if you see third, fourth, and sixth. Third is oculomotor, fourth is trochlear, and sixth is abducent. Again for the eye, this is important structure. So three nerves are there. Third, fourth, and sixth are for the motor action, movements supplying to the eye muscles. So just think of this. Eyes has got a very special sense, and three muscles are acting. Three cranial nerves. Oh, sorry, not three muscles. Three cranial nerves are dedicated for the eye actions, eye movements. That is oculomotor, trochlear, and abducent. So to remember, trochlear is called as SO4 most of the time, supplying to superior oblique. Fourth nerve is supplying SO4, and sixth nerve is LR6. So these are the two important movements. Lateral rectus is moving, eye on the lateral side, superior oblique is moving the eye on the downward and inward direction. So whenever paralysis is there, the person gets difficulty in walking down, that is SO4, and LR6, person is unable to see on the lateral side, so lateral gaze palsy. So this was about the motor nerves supplying to the eye muscles. Then you see 11 and 12 is also purely motor, accessory, and hypoglossal. Again for the tongue, this is special 12th nerve is there, and accessory muscles of the this trapezius and sternocleidomastoid. Then remaining four nerves, you just remember important nerve is trigeminal. TG has got three divisions: facial nerve, then glossopharyngeal, and vagus. These are sensory as well as motor mixed. So to remember is 10/9/7/5, 1975. So this is about, in short, about the cranial nerves. Trigeminal, basically sensory to face, as well as sensory to face and motor to muscles of mastication or chewing. The nerve of the first arch. Then seventh is sensory to most of the tongue and inner surfaces. Then muscular to the facial muscles of expression. Chewing, expression is smile. Then swallow and all that, that is glossopharyngeal. This is again the pharyngeal nerve. So how it is called to remember the arches: chew, smile, swallow, and eighth is to speak for vagus. Chew, smile, swallow, speak. These are for the arches. So first arch, trigeminal nerve of the first arch, trigeminal. Then second arch nerve is facial. Third arch, glossopharyngeal. Fifth is not there. Sixth, fourth and sixth is vagus nerve. So what are the concern questions regarding this optic nerve? So this you can see, if suppose this is the eyeball, this is the medial side, this is the lateral side of the eyeball. You can see medial side of the eyeball is having a vision of the lateral side, so that is called as temporal area. This is temporal area, this left eye. So medial side, the fibers are passing from the optic nerve, then there is optic chiasma, then from optic chiasma there is decussation of the medial side fibers to the opposite side of the occipital cortex, and lateral side is going on the same side. So any injury in the optic nerve itself, so that will lead to loss of total vision on the same side, so that is called as monoocular vision. That is one thing. If the injury is in the central area, so what has to happen, the medial side fibers which are decussating, they are going to lose the vision. So if you lose medial side, so this is the reflection just like a mirror, unable to see on the lateral side, so that is called as bitemporal, or you call this as a tunnel vision. As if you are passing through a tunnel, you are unable to see from the side. So this is just like this one, this has become black. So you are passing, when you are passing through the tunnel, you will see this like this curve. The questions are, you get a tunnel vision means bitemporal hemianopia, and the lesion is at the optic chiasma. Next after that, the nerves decussate and goes through the optic tract to lateral geniculate body, then optic radiation to the optic radiation to the then the occipital cortex. So anywhere behind this, either in the optic tract, optic radiation, or occipital region, so you get, what you get is contralateral opposite side. So you get contralateral homonymous hemianopia, means a vision of this will be lost. Contralateral homonymous hemianopia, so vision will be like this, half of this temporal side, half of the medial side will be lost. So homonymous hemianopia. So these are the questions about optic nerve. Then the first is the olfactory nerve. Any injury to the cribriform plate, that will lead to loss of smell sensation. All that the questions regarding first nerve is regarding smell. Second is vision. Third, fourth, and sixth, as I have told, these three nerves are motor nerves for the eyes. That was initially, this optic was sensory. It is carrying the vision. So how it is tested? Reflecting the light. The light is getting passing through this. This is sensory nerve for the light sensation. Now, oculomotor, trochlear, and abducent, these three nerves. So if you just try to remember the origin, remember the numbers 2, 2, 4, 4. 2 are from the forebrain, the next 2 are from midbrain, pons, and medulla. So if you see 1 and 2, olfactory optic is from the forebrain, then next 2, third and fourth from the midbrain, then next 4, 5th, 6th, 7th, 8th from the pons, 9, 10th, 11th, 12th from the medulla. This is also some of the times questions are asked. To remember is that 2, 2, 4, 4, 2 nerves from first forebrain, 2 nerves from the midbrain, pons, medulla. Just try to remember this. Oculomotor and trochlear, as I told, it is from the midbrain. This is from the midbrain. Superior colliculus, inferior colliculus. Just remember this one. The important thing is, oculomotor is supplying to major nerves, major muscles of the eyeball: superior rectus, inferior rectus, inferior oblique, medial rectus. Just remember the name: superior rectus elevating, inferior rectus depressing, inferior oblique medial movement, rotation. Inferior oblique is just like downward movement, and medial rectus is medial movement. So SO4 is for the fourth nerve and LR6 for the sixth nerve. This is the action. If there is injury to third nerve, it occurs lateral squint due to intact LR6. What happens? Divergent squint. And if you see here, In LR6 there is convergent squint. Convergent in sixth nerve injury and divergent in third nerve injury, as lateral rectus is intact. So if you see, if third nerve is paralyzed, so what is doing? LR6 is moving on the lateral side and SO4 is trying to move it down. So downward and outward movement. So oculomotor paralysis, left side, left eye, third nerve palsy is there in this. SO4 is working, trying to move down, and LR6 is working, trying to move lateral. So that is causing divergent squint. This is divergent squint. Dilatation of the pupil, mydriasis. So constriction and dilatation is to the third nerve. So on response to light or near reflex, which is first sign may appear. This also question is blown pupil. Blown pupil. It is third nerve. So and drop of the eyelid, ptosis, levator palpebrae superioris. This is for the upper eyelid. So third nerve is for the upper eyelid, not is the major. It's not to the major muscle. So ptosis is there, dilated pupil is there, divergent squint is there for third nerve palsy. A fourth nerve palsy. What is the action of fourth nerve? It is doing superior. It is superior oblique muscle. Superior oblique. Smallest nerve damage causes diplopia when looking downwards. A person is unable to see. If you see in this, right trochlear, downward and inward. So in this left eye, this is normal. Right eye, a person is able to look downward, and in this the eye is unable to move down, and there is oblique. So whenever a person is walking down, so you have to move your eyeballs downward to the steps. So left side is able to move down and out also. Here the right eye is unable to move down. That's why you are getting, when you're looking downwards and medially as walking downwards, it's difficult. A person cannot do it. So whenever you are trying to look downwards and medially, left eye is able to move laterally, but right eye is unable to move even to medially. You can see the sclera here. So the medial movement and downward movement is lost. Oblique is doing action to look medial and down. Just when you try to look at the tip of the nose with both the eyes. See, if you try self to look at the tip of the nose with both the eyes, that is the action of superior oblique. So that action is required when you are looking at your foot, moving down. So moving downward become difficult in SO4 palsy. LR6 is simple. You put your hand, a finger in front, and try to move the finger on the side. Eye which is normal will move on that side, but the eye which is abnormal, it is unable to move on the lateral side. So here if you see, you have put a finger like this in the center and you are moving this finger on this side. So this eye is unable to move laterally, but this eye is moving medially. That's why lateral gaze is not possible. Lateral gaze has lost. So that is convergent squint, or inability to abduct the eye. So in the intracranial trauma, whenever there is injury to inside the brain, that may cause fixed dilated pupil. Sometimes fixed and dilated pupil due to compression and injury in oculomotor parasympathetic. This is one of the questions asked most of the time about parasympathetic fibers, oculomotor, supplying to oculomotor nerve. So that may cause dilatation. Third nerve palsy, parasympathetic fibers. And second is unopposed sympathetic stimulation. This is another question. So ipsilateral, same side pupil dilated, intracranial pressure, that is blown mute. Now again, these are the actions of the muscle. Most of the questions not on medial rectus. The important is superior oblique, abduction, depression, internal rotation. So internal rotation as well as downward movement, and lateral rectus. This is the next important thing is pupillary light reflection. So whenever you put a torch in the eye, it blinks suddenly. So that is called as light reflex. It is not touch reflex. Huh? Don't confuse with the touch reflex. This is light reflex. Afferent is carried by the optic nerve. Optic nerve is carrying the light sensation, and sudden blinking is because of oculomotor nerve, third nerve. If light is directed to the affected eye, then there is no response. If suppose this eye is optic nerve is damaged, even if light is not traveling, so there will be no blinking. So that is called as Merkus gun pupil. But when you put a light on normal eye, so it will blink on the both sides. Coming to the next nerve, accessory and hypoglossal nerve. These are again the two motor nerves. This is 11th nerve and this is 12th nerve. So we have just skipped the other nerves that will be important nerves. 5th, 7th, 8th, 9th, 10th. They are important. That's why they are kept afterward. So now let's go for the accessory hypoglossal. The important part is it has got two roots, cranial and spinal root. Spinal root, which is starting from the spinal cord, it has to go inside the skull, and it is entering to foramen magnum inside and joins the cranial root and again comes out through the jugular foramen. So this is the question. Spinal nerve is coming out of jugular foramen but goes into the foramen magnum, then passes in the posterior triangle. This is the important thing again. It is passing through the posterior triangle. So any injury on this site will cause to this motor functions of accessory nerve. Posterior triangle lymph node, posterior triangle lipoma, posterior triangle any dissection, injury to accessory nerve. Posterior triangle of the neck, any injury to spinal accessory nerve. The course is between 1/3. Now again, this is one of the question. How is the course? If you are trying to make surface anatomy, there are 5 important points. This is the tragus of the ear, 1 point. Then atlas vertebra, palpate here. Then this is the sternocleidomastoid, upper 1/3 and lower 2/3 anterior border. Then the posterior border, middle of the posterior border of sternocleidomastoid. Point at the then sclera. This is the anterior border of trapezius, just 5 centimeter above the clavicle. If you join these 5 points, you can trace the point between upper third and lower third of anterior sternocleidomastoid. So anterior border of sternocleidomastoid, midpoint of the posterior border of sternocleidomastoid, and 2/3 and lower third of trapezius. This is just tracing the accessory nerve, and it is supplying to both muscles also, sternocleidomastoid and trapezius. And it's arising from the jugular foramen, passing into the posterior triangle. See, sternocleidomastoid is dividing the neck into anterior triangle and posterior triangle. So it is passing just from the tragus of the ear, crossing the sternocleidomastoid muscle, and it is passing from the posterior triangle. So lot of this nerve has got a long root inside the posterior triangle, and it is transversely crossing, obliquely crossing to the posterior triangle. That's why chances of injury is more. So and it causes paralysis of trapezius, leading to motor trapezius, shrugging of the shoulder is lost. If motor to sternocleidomastoid, response for torticollis. These are the two functions. Just try to remember: accessory nerve, two roots, two muscles, two foramina, posterior triangle, and loss of sensation, loss of motor function of trapezius is difficulty in shrugging, loss of motor sensation to sternomastoid is torticollis. Hypoglossal nerve, its origin from the medulla, exit through the hypoglossal canal, same name, crosses transversely. One nerve was crossing posterior triangle, this is transversely crossing to anterior side, external carotid artery, passes deep posterior digastric and styloid muscle, reaches tongue. This is supplying to the muscles, extrinsic muscles of the tongue, except palatoglossus, which is supplied by, just remember, palate is supplied by vagus nerve. So movements of the tongue, and whenever there is any injury, there will be ipsilateral, same side. The question is again ipsilateral deviation of the tongue. So you can see here hypoglossal is crossing anteriorly. So again the great vessels are there, external carotid and there. Whenever end carotidectomy and then there is chance of injury to hypoglossal nerve, and it has got, if you see, it is a 12th cranial. After that cervical vertebra is starting. So this is end of the medulla oblongata. Then there will be C1 nerve. So C1 is passing attached to the C1, C2, C3, and they forms a loop that is called as ansa cervicalis. Again, this is important. Ansa cervicalis first is along with hypoglossal, it is mixing with hypoglossal. The importance of ansa cervicalis is that it is supplying to all the muscles called as infrahyoid muscles. This is the hyoid bone. Below this hyoid bone, these are the strap muscles. They are called as ptos, thyroid, omohyoid, styloglossus. Stylo. Among this, only thyroid is the muscle which is supplied by first C1 as with hypoglossal, but rest of the three muscles are supplied by ansa cervicalis.